In this section, we will discuss about the arrhythmia management with particular emphasis on device therapy. For the treatment of rhythm disorders, anti-arrhythmic drugs is usually the first line of choice. But drugs can have side effects or adverse effects. Ablation or surgical procedures is another option. It removes or destroys conductive tissue or tissue responsible for arrhythmia onset, and is non-reversible and offers permanent cure. For example, this is AV nodal ablation, so-called ablate and pace in patients with refractory atrial fibrillation. This procedure isolates atria from ventricles because it creates a complete AV block and it requires permanent pacing. It did not cure AF, but it will regulate the rhythms and it will control the symptoms of refractory AF. Focal ablation is also another form of ablation procedures. These pulmonary ring ablations will alter circuit or pathway of arrhythmia origination. Of course, there will be risk of pulmonary ring stenosis. Another form is linear ablation. We can perform linear lesions through reentry circuit, and it can prevent reentry tachycardias. Surgical MACE procedures is a recognized treatment option for AF. It's open heart surgery for treatment of atrial fibrillation. A MACE of electrically isolated incisions will be made in atrium. External electric therapy is also an option for treatment of arrhythmias. You see in this cartoon, when the heart is in ventricular fibrillation with no organized contraction, the only effective treatment is defibrillation. You see, by applying defibrillation, the heart can be restored to sinus rhythm. So when the heart is fibrillating, it's important to defibrillate the heart and turn the heart into sinus rhythm. This external electric therapy is very important. It's a shock delivered through external paddles positioned on patient's chest. It's for emergency rescue of VT or VF or planned therapy for AF. It's sometimes painful or uncomfortable to patients. So with the cardio version for planned AF, sometimes sedation is necessary. And it's better to give adequate sedation to patients before planned cardioversion. It's also important to note that the external electrical therapy is important, and electro placement is very important to allow proper and effective external electrotherapy. As shown here, the incorrect electro position will give rise to ineffective defibrillation or cardioversion, where this correct electro position will optimize the amount of current flows through ventricle. Implantable devices nowadays is an important therapy for rhythm disorders. We have different forms of devices. Broadly, it can divide into pacemakers and ICD. That's implantable cardioverter defibrillators. The pacemakers delivers electrical impulse that causes heart to beat. It serves to increase or regulate a rhythm. The ICD can deliver electrical shocks or anti-tachycardia pacing, so-called ATP, to terminate fast rhythms. It can also function as a pacemaker. Let's first look at the ICD. In 1985, implantation of ICD is very cumbersome. The device is big. You have to put in the abdomen with epicardial patch. In 1991, it's better, but still, you need to put the device in the abdomen. And with subsequent advance, in 1995, the pectoral ICD is available. So previously, we require major surgery The device is non-programmable, only high-energy shock is available, and at that time, it's only indicated for patients with 2 times sudden cardiac arrest, and the longevity is short, and the implant number is not high. But nowadays, transvenous single incision is adequate. There's local anesthesia and conscious sedation instead of general anesthesia is required. There's lots of programmable therapy options, and with single lead, dual lead, and also triple chamber ICD is available. And longevity is much, much longer, and the implant number increased rapidly. So if you look at the history, the first human implant of ICD starts in 1980. With the FDA approval in 1985, the number of ICDs gradually increased. And with all this major trial and AFib care series, a lot of trials show that the secondary prevention is very important. ICD is very important in secondary prevention of patients with sudden cardiac arrest or VT. And with more modern trials, for example, the SCUT-HEF trial, it also shows that the primary prevention of sudden cardiac death by ICD is also very effective. So the number of ICDs actually increase more and more. So the ICD system, actually, we include the ICD, the device, and the lead, and also the programmer is also an important part of the ICD system. So how it works. Nowadays, the leads are like pacemaker leads, are put in transvenously. So the lead can be put through the subclavian vein or cephalic vein into the right ventricle, and then with the cant, then it will work as a defibrillator. So how it works? Actually, in the ventricle, the lead and the device can provide anti-tachycardia pacing, sometimes abbreviated as ATP, or it can provide cardioversion or defibrillation. If you put a lead in the atrium, the lead in the atrium ventricle can provide bradycardia sensing, bradycardia pacing, and also anti-tachycardia pacing. So a lot of work can be done by this device. How about the device therapy for bradyarrhythmia? Pacemaker is an important and common therapy options for patients with symptomatically important bradyarrhythmias. And the indications for pacing is usually significant symptomatology plus documented arrhythmic events. The symptoms sometimes may be varied and can include irritability, fatigue, forgetfulness, palpitation, chest pain, dyspnea, and sometimes maybe a severe syncope. And the documented arrhythmic events can be documented by electrocardiogram. Sometimes it needs to be documented by 24-hour Holter monitoring. Two-table testing and EP testing sometimes are necessary. For the indications for pacing, the commonest indications nowadays in clinical practice are Saxena syndrome and advanced heart block. Other indications include carotid sinus hypersensitivity or post-RF ablation. Let's look at the NASP and the BPEG code. The NASP means North American Society of Pacing and Electrophysiology. Now it's called the Heart Rhythm Society. And the BPEG is the British Pacing and Electrophysiology group. And this code is widely used for communication. The first position means the chamber pace. It can be atrium or ventricle or dual chamber. The second position depicts the chamber sense. Again, it can be atrium, ventricle, or dual. And the third position is response to sensing. It's either trigger or inhibited or dual. And the fourth position means the rate modulation, whether there's rate modulation capacity. And the fifth position means multi-site pacing. So if a VVI means this is the ventricle is paced and ventricle is sensed as an inhibit mode. If a DDDR means a dual chamber pace, dual chamber sense, and also the response to sensing is dual, and also it's a rate responsive. If you look at the history of pacemaker, previously the pacemaker is very big, like nowadays ICD, or even bigger than the ICD nowadays. It's very big, very complicated device. But nowadays the pacemaker, very small. So again, it involves the device and the lead and also the programmer. So pacemaker components actually combine with the body tissue to form a complete circuit. We have the pulse generator, the power source or the battery, and then with the lead or wires, and then with the cathode and anode, and then with the body tissue. This forms a complete circuit. For the pulse generator, here are the pulse generators. It contains a battery that provides energy for sending electrical impulses to the heart. It also houses a circuitry that controls the pacemaker operation. So this battery and circuitry are major components of the pulse generator. The leads can be put in epicardially or endocardially. So what are the leads? The leads are the insulated wires that delivers electrical impulse from the generator to the heart. It also sends the cardiac depolarization. So these are the components of a pacing lead. There's a distal tip electrode, there's a proximal ring electrode, and in this example, there's an active lead, so it's the active fixation mechanism. It's a bipolar lead with the two electrodes, and this is the lead body. This is the suture sleeve that allow us to secure the leads to the body tissue, and this is connected to the pulse generator. So for the leads, there are passive fixation lead and the active fixation leads. And here are examples of transvenous leads, the passive fixations. Here you can see the tines. These are the tines that become lodged in the trabeculates. That is the fibrous meshwork of the heart, and helps to fixate the lead to the heart. And here are the active fixation leads. You see there are helix or screw which can extend into the endocardial tissue and allows for lead positioning anywhere in the heart's chamber. And we have also the unipolar and bipolar lead. For unipolar, only the tip electrode is present. For the bipolar lead, the tip electrode and the ring electrodes are present. So here, example of a unipolar, just the tip electrode and the pacemaker will act as an active cant. And here, example of bipolar, the tip electrode and the ring electrodes are present. So what are the difference? For the unipolar leads, it's a large antenna. Large spikes can be seen. It will be more sensitive to interference, and the pectoral muscle stimulation sometimes can be a problem. It's more susceptible to electromagnetic interference. Maybe the advantage is smaller lead diameters. For the bipolar lead, a small spike is present. It's more sensitive to intrinsic cardiac signals. There's no mild potential inhibition, and the electromagnetic interference protected at their next cross-talk. Nowadays, I think most of us will use bipolar leads. For the pacing threshold, we usually use steroid uterine leads, because if you use the steroid uterine leads, the threshold is better. There will not be acute increase in threshold. Like if you use a no steroid in the lead, there may be acute rise in the pacing thresholds after transplant. So if you use a steroid uterine leads, the threshold is better. We sometimes, or we usually actually, allow safety margins. That is the ratio of measures capture threshold to program output. We usually allow it at least 2 times. That is the programmed output of the pacemaker is usually 2 times the capture threshold to allow a reliable capturing of the ventricle or atrium if needed. So, what is a single chamber or dual chamber pacemaker? For a single chamber system, the pacing lead is implanted in atrium or ventricle only. That is, one lead is used and is implanted in the atrium or the ventricle only, depending on which chamber to be paced or sensed. So in this example, the lead is only paced the ventricle. Here, an example of a single chamber pacemaker. The lead is pacing in the ventricle only. So this is a pacemaker. This is a ventricular lead putting into the right ventricular apex. So if you look at the pace rhythm recognition, you see here, this is a atrial pace rhythm. This is a single chamber pacemaker pacing the atrium only. And this is A pace. And here, because the atrial rate is faster than the pacing rate, so it's A sense, the pacemaker do not need to pace the atrium. It's A sense and A sense. This is the AAI. And here is a single chamber ventricular pacing. You see this ventricular pace here, ventricular pace here. This intrinsic rhythm comes earlier than next pacing beat. So it's a spontaneous ventricular beat. It's a V sense, V pace, and V sense. It's a VVI pacemaker. So what is the advantages and disadvantages of a single chamber pacing system? The advantages, of course, is much more simpler implantation. It just involves a single lead. But the disadvantages include the single ventricular lead did not provide AV synchrony. This is very important, especially for some patients. And single atrial lead does not provide ventricular backup if atrial reconduction is lost sometime later. So this is a dual chamber pacemaker. It has two leads, one lead implanted in atrium and the other lead implanted in the ventricle. So this is the atrial lead. This is a ventricular lead. The ventricular lead is in the right ventricular apex, and the atrial lead is in the right atrial appendage. This is a dual chamber pacemaker. And again, the pace rhythm recognition. This is the A sense V pace, A sense V pace. So it's a DDD pacemaker. Rate responsive, also called rate modulated pacemakers, it provides patients with the ability to vary the heart rate when the sinus node cannot provide appropriate rate. So it's indicated for chronotropically incompetent or heart rate cannot reach appropriate level during exercise to meet other metabolic demands, or in patients with chronic atrial fibrillation with slow ventricular response. This rate responsive pacemaker is very important. The electromagnetic interference is also of concern in patients who have implanted pacemakers. This includes cardioversion defibrillation, electrocautery, magnetic resonance imaging, ESWL, the so-called extracorporeal shockwave lithotripsy, therapeutic radiation, radiofrequency ablation. All this may have EMI to the pacemaker, and it is worth to look to precaution when using this device. So in summary, most pacemakers will perform four functions. It will stimulate the cardiac depolarization, it will sense the intrinsic cardiac function, and will respond to the increased metabolic demand by providing the rate-responsive pacing, and it will also provide the diagnostic information stored by the pacemaker.